Hi, I'm Dr. Altaf, and today I want to talk about something that quietly affects millions of people over 50, and most of them have absolutely no idea it's happening. There's a category of very common medications. Medications for allergies, sleep, bladder control, anxiety, and digestive issues that have been linked in multiple large research studies to an increased risk of dementia and measurable changes in brain structure. These aren't obscure drugs. They're not experimental. Many of them are sold over the counter at every pharmacy. Some of them are probably in your medicine cabinet right now. And the reason I want to talk about this today is not to frighten you. It's because understanding this could genuinely help you have a more informed, more productive conversation with your doctor. So let's get into it. The class of medications I'm talking about is called anticholinergics. I know that's a mouthful, so let me break it down simply. Anti means against. Choline refers to acetylcholine, one of the most important chemical messengers in your brain, and ergic just means affecting or related to. So anticholinergics are drugs that work by blocking the action of acetylcholine in your body. Now, acetylcholine plays an enormous number of roles. It helps your digestive system move smoothly. It helps regulate your bladder. It controls secretions like saliva and mucus, which is why antihistamines dry you out. And in your brain, it is a critical neurotransmitter involved in memory, attention, learning, and the ability to focus. Think of acetylcholine in the brain as the communication signal that keeps neurons talking to each other efficiently. When that signal is blocked, even partially, things slow down. In the short term, you might notice brain fog, confusion, or slower reaction times. That's not a coincidence. That's the mechanism working exactly as it's designed to. The clinical concern with long-term use is that repeatedly dampening acetylcholine activity over months and years may do more than just cause temporary fogginess. So what does the research actually say? Let me walk you through this carefully, because I want to give you an honest picture, not an alarming headline. There have been several large observational studies and meta-analyses examining the relationship between long-term anticholinergic use and dementia risk. A systematic review and meta-analysis that pooled data from over 1.5 million people found that anticholinergic drug use was independently associated with a higher risk of all-cause dementia and Alzheimer's disease, and that heavier cumulative exposure was associated with a correspondingly higher risk. Another meta-analysis that analyzed 21 individual studies found that anticholinergic use for more than 3 months was associated with roughly a 46% higher risk of dementia compared to non-use. And a study published in JAMA Neurology used brain imaging and metabolic assessments and found that anticholinergic medication use was associated with measurable reductions in brain volume and changes in how the brain processes energy, meaning the effects weren't just functional, they appeared structural. Now, and this is really important, I want to be honest with you about what this evidence does and doesn't tell us. These are observational studies. They show associations, not proven causation. People who take these medications long-term may also have other conditions, lifestyle factors, or health profiles that independently increase dementia risk. Researchers do their best to control for confounding variables, but you can never fully eliminate them in this kind of research. That does not mean we should dismiss these findings. The consistency across multiple large studies is genuinely concerning and absolutely worth discussing with your doctor. But it does mean we should be measured, not panicked, in how we respond to this evidence. Now let's talk about which medications fall into this category, because this is where things get practically useful. The most well-known anticholinergic you've probably encountered is diphenhydramine, better known as Benadryl. It's sold as an allergy medication, but it's also the active ingredient in most over-the-counter sleep aids like Tylenol PM and Unisom. If you look at the label of a nighttime pain reliever or a sleep aid at your pharmacy and you see diphenhydramine on the ingredient list, that's an anticholinergic. Some anxiety medications also fall into this class. Hydroxyzine, sold under the brand names Vistaril and Atarax, is commonly prescribed for anxiety and as a sleep aid, and it has significant anticholinergic properties. Bladder control medications are a major category here. Drugs like oxybutynin, brand name Ditropan, and tolterodine, brand name Dutrol, are widely used for overactive bladder, and both are anticholinergic. Some antispasmodic medications used for irritable bowel syndrome, like dicyclomine, also fall into this class, as does the motion sickness patch containing scopolamine. What's important to understand is that none of these medications is inherently villainous. They all exist because the conditions they treat are real, sometimes debilitating, and genuinely affect quality of life. Taking a diphenhydramine for 1 or 2 nights when you simply cannot sleep. That's a very different situation from taking it every night for years. The concern isn't acute, occasional use. The concern is cumulative, long-term exposure. And this brings me to something I see frequently in clinical practice that I think is underappreciated, what researchers call the cumulative anticholinergic burden. Here's what that means. Each individual anticholinergic medication partially blocks acetylcholine activity. If you're only on one, the effect is limited. But many people, especially older adults managing multiple conditions, end up on 2 or 3 of these medications simultaneously without realizing that each one adds to the total burden on the cholinergic system. For example, someone might be taking hydroxyzine for anxiety, diphenhydramine for sleep, and oxybutynin for bladder control. Each prescription came from a reasonable clinical decision, but when you add them up, the combined anticholinergic effect on the brain can be substantially greater than any single medication alone. This is exactly the kind of thing that's worth reviewing with your doctor. Not in a crisis, not with alarm, but as a proactive, informed conversation about your long-term brain health. And I want to emphasize this clearly. Do not stop any of your medications on your own based on this video or any video, please. These medications are managing real symptoms, and stopping abruptly without medical guidance could cause harm. The goal here is informed conversation, not unilateral action. Now, there's another layer to this that matters, especially if you're over 60. As we age naturally, acetylcholine production in the brain tends to gradually decline. That's a normal part of aging, but it also means that older adults may have less physiological reserve to buffer the effects of medications that further reduce acetylcholine activity. The same medication that causes minimal cognitive impact in a 35-year-old may have a more pronounced effect in a 70-year-old simply because the baseline is different. This doesn't mean that older adults can never take these medications. It means the risk-benefit calculation is different, and it deserves more careful, individualized attention. If you're over 60, or if you have any existing concerns about memory or cognitive function, or if you're currently taking more than one of these medications, that conversation with your doctor becomes even more important. So let's talk about what practical steps look like, because I don't want to leave you with a list of concerns and no clear direction. The first thing I'd encourage you to do is take an inventory of your current medications, both prescription and over-the-counter. Write them all down. Include sleep aids, allergy medications, anything you take regularly. Then ask your doctor or pharmacist whether any of them are anticholinergic. Pharmacists are genuinely excellent at this kind of medication review, and it's exactly what they're trained to help with. If you're taking a medication primarily for sleep, there are alternatives worth exploring with your doctor. Melatonin, particularly at lower doses, has a reasonable evidence base for supporting sleep onset. Magnesium glycinate or magnesium threonate has been studied for its potential role in sleep quality, though evidence varies. Among prescription options, trazodone is widely used for sleep and has minimal anticholinergic activity. For allergies, the second-generation antihistamines, cetirizine, which is Zyrtec, loratadine, which is Claritin, and fexofenadine, which is Allegra, have been specifically designed to minimize penetration into the central nervous system compared to first-generation antihistamines like diphenhydramine. They're generally considered a safer long-term option from a cognitive standpoint, though your doctor is the right person to advise you on which is appropriate for your specific situation. For overactive bladder, a medication called mirabegron, brand name Mirbatric, works through a completely different mechanism and is not anticholinergic. It's worth asking your doctor if it's appropriate for you. It does carry its own considerations, including potential effects on blood pressure, so it's not universally suitable, but for many people, it represents a meaningful alternative. For IBS and gut spasms, your doctor can advise on options depending on your specific symptom pattern, whether it's predominantly constipation or diarrhea. And there are non-anticholinergic directions worth exploring together. One more thing I want to address, because I know some of you watching this may have been on one or more of these medications for years, and you might be feeling worried right now. Here's what I want you to hear. Please don't panic. The research shows associations and increased risk. It does not show that every person who has taken these medications will develop dementia. Risk factors are not destiny, and whatever your history with these medications, there are real evidence-supported things you can do right now to support your brain health going forward. Regular physical exercise, and I mean genuinely regular, something you sustain over time, is one of the most consistently supported interventions for reducing dementia risk across the research literature. Prioritizing sleep quality quality matters. Managing conditions like high blood pressure, insulin resistance, and cardiovascular disease matters enormously because these are independent risk factors for cognitive decline that compound with other vulnerabilities. Your brain has a remarkable capacity for resilience. The goal is to give it the best possible environment to express that resilience. And that starts with being informed, asking the right questions, and working with your doctor as a true partner in your care. If this video was helpful to you, and I genuinely hope it was, I'd be grateful if you'd subscribe to the channel. Everything I make here is built around one idea, that you deserve accurate, honest health information that respects your intelligence and supports your ability to make good decisions for yourself and the people you love. There's a lot of noise in the health content world, a lot of exaggeration and fear. My goal is to be something different, a voice you can actually trust. So if that matters to you, subscribe. Share this with someone who might find it useful, and I'll see you in the next video.